Hi everyone, good evening. This is week 4, fourth semester APU pre-conference for this week. This evening I will cover a range of the urinary and renal disorders that you would see in acute care. So we'll talk about anything from UTIs to acute kidney injury to chronic disease and nephritic syndromes. So the focus will focus on signs and symptoms, nursing priorities, and test taking tips as normal. And always think renal function, which equals fluid balance, electrolyte balance, and waste removal. So let's get started. Okay, so let's talk about UTIs. This is pretty common in the hospital. So the most common causative bacteria is E. coli. This causes about 75 to 95% of all community-acquired UTIs. You also can have hospital-acquired, which would be considered complicated UTIs, and they're usually multi-drug resistant, also known as MRSA. So Pseudomonas ESBL organisms also fall under that category. So for your risk factors, your demographics, typically women are more common to get UTIs due to having a shorter urethra, which means it's closer to your anus. And also postmenopausal women because they have lost estrogen, which will alter your vaginal flora. So some medical conditions you should be thinking about that will put patients, at a higher risk for developing UTIs would be patients with diabetes mellitus. So if they have glucose in the urine, that would promote, bacterial growth and impairs immunity. Any patients that are immunocompromised, any patients that have urinary retention or obstruction. So some diseases you should be thinking of would be BPH, any patient who has a ureteral stricture or a neurogenic bladder. So some procedures and devices that have been used, Foley catheters, but again, those can cause CAUTIs, which are catheter-associated UTIs, and then anyone who's had recent urologic surgeries. Some behaviors that can also cause urinary tract infection is frequent sexual activity, not urinating after coitus, use of spermicides or diaphragms, and then also poor hygiene. Signs and symptoms of a lower UTI, so this is cystitis or urethritis, would be dysuria, which is burning with urination, urgency, the frequency. Some patients may complain of abdominal pain or suprapubic pain. It's pretty specific. They may also have cloudy or foul-smelling urine or blood in the urine. For upper UTIs, that's considered pyelonephritis, so your patient may present with fever, chills, flank pain, nausea, vomiting, CVA tenderness as well. So it's really important to ask all those questions to get a better picture of your patient. And then in the elderly or immunocompromised, they present atypically, so not your typical presentation. So they can present with confusion, delirium, anorexia, and often they don't have a fever. So for diagnosing these, the tool that we use is the urinalysis. So that will be positive for nitrates, which is saying that, there's gram-negative bacteria in there, and you'll also have leukocytes present in the urine as well, along with pyuria and hematuria if it's pretty bad. You'll then want to do a urine culture and sensitivity if you do have a positive urinalysis for bacteria, and that will be more definitive. It's going to tell you what specific bacteria is growing just to make sure that we're treating it properly. So for NCLEX tip, you're always going to obtain cultures before starting antibiotics if it is at all possible. For uncomplicated cystitis, it's usually treated outpatient. You guys may have heard of Macrobid or Bactrim or fosfomycin if your patient is pregnant. One thing that you do need to be mindful of with Bactrim is patients need to have good kidney function with that medication. It can be hard on the kidneys, so patients do have to stay extra hydrated when they are placed on Bactrim. If it's a complicated UTI, so it's traveled further up the urinary tract, it would be pyelonephritis, anything in a man or pregnancy. So you use a fluoroquinolone, ciprofloxacin, you guys may have heard of, or levofloxacin, or a beta-lactam, so amoxicillin clavinate, also known as Augmentin, or any cephalosporin will also help as well. Hospital-acquired catheter-related, if it's a CAUTI, you're going to remove, obviously, the device that's causing it. It's going to be tailored to the culture results, okay? So it may require more broad-spectrum IV antibiotics initially as well. So to prevent UTIs, you're going to encourage your patient to hydrate, which flushes bacteria. You want to tell them that they need to urinate after sexual activity. They should be wiping front to back. That's like hygiene 101. So making sure that they are doing that and avoiding spermicides and diaphragms if they're having recurrent UTIs. If the patient has catheter care, you're only going to insert it when it's necessary. You're going to maintain closed drainage system and sterile technique when inserting, and you want to remove it as soon as possible. If the patient is having reoccurring cases, they may be placed on a low dose of prophylactic antibiotics or topical vaginal estrogen if it's a patient that might be postmenopausal. For NCLEX tips, elderly patients with confusion, you're always going to think UTI. If patient is septic from a UTI, the priority is fluids and IV broad spectrum antibiotics. Nitrofurantoin, also known as macrobid, you're going to make sure your patient takes with food. It may also turn the urine brown. That is normal. And then you're going to teach prevention, so hydration, hygiene, and voiding habits. Okay, we're moving up the urinary tract. So now we're at pyelonephritis. So the infection moves up to the kidneys level now. So the patient will, report flank pain, fever, chills, nausea, vomiting, CVA, tenderness. They may have like a lower blood pressure. Their heart rate might be slightly tachycardic. So this puts the patient at risk for like abscesses, going septic, urosepsis, and renal scarring as well, just from the injury and the bacteria. So your nursing interventions are going to involve hanging IV antibiotics, fluids, pain control, monitoring for superimposed acute kidney injury. Okay, next we'll talk about acute post-streptococcal glomerulonephritis, such a big word. So this happens following strep infections. It's common in children. The patients may present with hematuria, red blood cell cast, mild to moderate protein in the urine, edema, and hypertension. It can be pretty bad and it can lead to chronic glomerulonephritis, so it does need to be treated, and it can also, injure the kidneys as well. So something to look for if you have a patient who is post-streptococcal. Their urine also can turn like Coca-Cola color, so that's something else to look for as well. Chronic glomerulonephritis is a slow progression. This often leads to chronic kidney disease. So for chronic kidney disease, you'll need to know stages. So GFR is pretty important there. It's persistent protein in the urine, hematuria, and renal insufficiency. Nephrotic syndrome is when the patient is spilling massive protein in their urine, over 3.5 grams per day. They have hypoalbuminemia, edema, especially periorbital, pretibial, hyperlipidemia, and hypercoagulability. So complications here puts the patient at increased infection risk and thrombosis. So nursing interventions would be to monitor protein, albumin, edema, fluid status, and prevent further infections. And then NCLEX tip, in nephrotic syndrome, you're going to watch for hypercoagulability because that puts the patient at risk for DVTs and renal vein thrombosis. Okay, phenochromoscytoma, we don't really talk about it a lot, but this is a catecholamine secreting tumor of the adrenal medulla. Remember, your adrenal medulla sits right on top of your kidney, so I call them kind of the kidney party hats. So you would have episodic hypertension. The patient may complain of headaches due to the hypertension. Your patient might be diaphoretic. They may have palpitations or anxiety. So you're going to want to monitor that blood pressure, tell your patient, hey, we're going to avoid stimulants, and make sure you know foods that are considered a stimulant. So coffee, any type of like chocolate, anything like that. Teas you have to be careful of as well. So prepare for surgical removal of that catecholamine secreting tumor. So NCLEX tip, these patients are extremely sensitive to blood pressure changes, so you want to avoid abrupt manipulation. Okay, so we're going to talk about renal calculi, also known as kidney stones. So again, just the essentials, what you need to know. Anything further than that, you should be looking in your textbook. So again, pathophysiology. It's hard deposits of minerals and salts that form in the urinary tract. There are several types of stones. There's 5. So the first one is calcium oxalate. These are the most common. So these are actually linked directly to dehydration and then high oxalate intake, so diet. So nuts, spinach, and tea. And I would know some high oxalate foods. That could potentially be a question that you would get on your NCLEX or your exam. Calcium phosphate, this is linked to alkaline urine, meaning as in the pH is a higher number, or hyperparathyroidism as well. Uric acid, which is linked to gout from a high purine diet, it's called the rich man's diet. So red meat, shellfish, organ meats, wine would cause an increase in uric acid levels. Struvite is usually due to infection. So urease produces bacteria, so Proteus and Klebsiella. And then cysteine, although it is a type of mineral deposit that forms a stone. They're pretty rare, but this is usually a genetic disorder that causes that. So some risk factors is dehydration. That's usually most important. The patient will have a family history of kidney stones. They eat a diet high in sodium, so animal protein, oxalate, or purines. Again, please know where your food sources are coming from. Please know appropriate diets and be able to identify, which foods your patient should avoid, because that's part of teaching, right? So obesity, metabolic syndrome, gout, hyperparathyroidism, Crohn's disease, malabsorption disorders, and then if your patient's having recurrent UTIs, especially with struvite stones, that puts them at an increased risk. So some signs and symptoms would be renal colic, sudden severe flank pain radiating to the groin, testicles, or labia. Hematuria, it can be gross or microscopic, which you can't see to the eye. Dysuria, urgency, frequency, stone near the bladder. So remember, dysuria, urgency, and frequency kind of sounds like a UTI, right? But now we're like, oh, this is actually a stone. So one of the bigger differences is the fact that you can have gross hematuria and then how the pain presents. So sudden severe, UTI was not sudden severe pain. Nausea, vomiting, diaphoresis, and possible fever and chills, indicating that they could be going septic from a stone. So it could be causing an obstruction, it could be an infected stone, which again would be a medical emergency. Your diagnostics that you'll be using will be a non-contrast CT, which is considered the gold standard. Make sure you know that. You can also use a KUB x-ray, which detects some, but not all of the stones, and a lot of stones do like to hide within the organs. So your analysis will show hematuria. You may have crystals that form. You may have signs and symptoms of an infection. And then you'll want to do a stone analysis after passage or removal. So a lot of times the doctor's offices, the urologist, or their mid-level, their APP, may say, hey, we're actually going to have you strain your urine to actually see if we can identify the source of the stone, because some of those stones are related directly to lifestyle modifications, factors, and also diet. So for treatment, you'll focus on pain control, IV opioids, NSAIDs, so ketorolac. Fluids, you're going to encourage oral IV hydration to flush the stones. You can also use tamsulosin or Flomax, which will relax the ureter smooth muscle to facilitate smoother passage of the stone. If the stone is small, less than 5 millimeters, typically they'll pass on their own. If they're having a large stone, an obstruction, or an infection, it does require intervention. Interesting story. My father, I would say probably 10 years ago, he had really bad back pain, and my parents do own a couple houses, so they do like work, and they were fixing things up, and out of nowhere my dad's like, oh my god, I'm having the worst back pain of my life. And my dad is like a big guy, right? He's like 220, he's solid, he's like 6'4", and all of a sudden he's healed over on all fours, like can barely walk. And I'm like, what is going on? Well, turns out my father had a kidney stone. So he hasn't had one since, thank God, but they can be pretty bad. So my dad's stone was pretty large, so due to his anatomy, they ended up doing the extracorporeal shockwave lithotripsy. One of the things that you do have to remember is any patients that are on blood thinners, those have to be stopped before lithotripsy, because it can cause severe bleeding. So ureteroscopy you can do, percutaneous nephrolithotomy, and you can also insert a nephrostomy tube if the obstruction occurs with an infection. So to prevent this, you're going to teach your patient to hydrate at least 2 to 3 liters a day, dietary modifications as well. So, limiting sodium and animal protein, reducing oxalate-rich foods if calcium oxalate stones are identified. And you're also going to want them to avoid purine-rich foods if uric acid stones are identified. Some medications, these are stone specific, so allopurinol for uric acid stones. You can use thiazide diuretics to reduce calcium stone risk, but remember, thiazide diuretics do play a pretty big role on your potassium levels as well. And then potassium citrate, they actually alkalize the urine for uric acid and cystine stones. So something else that could be done as well, depending on what type of stone has been identified. So for NCLEX tips, priority would be manage pain first, then fluids. If the patient develops a fever and obstruction, that is considered an emergency, and the patient is at risk for developing urosepsis. You're going to want your patient to strain all of their urine to collect stones for analysis. Hydration teaching, you're going to drink enough fluids to produce 2 to 2.5 liters of urine a day. So stones less than 5 millimeters, they usually pass. If they're greater than 8 millimeters, they likely will require one of the 3 procedures I talked about just a little bit ago. And then also, again, here's tamsulosin, which is a great medication. It's called Flomax. It can help relax your ureters, and you'll just have to teach the patient about orthostatic hypotension when they are first taking that medication. Okay, next we're going to talk briefly about bladder cancer. So typically bladder cancer is identified as like almost a transitional cell carcinoma. It's pretty painless. There's typically no pain. It's gross hematuria, which is like a classic cardinal sign. And then you'll have irritative voiding symptoms as well. For the nursing, you're going to monitor the blood in the urine. You're going to ensure adequate hydration, teach them after transurethral resection. Care for that and continuous bladder irrigation and monitor for bleeding. And then for the NCLEX tip, hematuria in older adults is presumed malignant until it is ruled out by biopsy. Okay, on this slide, I'm going to talk about urinary incontinence and retention. So incontinence, you have 4 different types. So stress, urge, overflow, and functional. For retention, that is considered the inability to empty bladder completely, which puts the patient at a risk for increased risk, for UTIs and bladder distension. So for nursing, you're going to bladder scan, you're going to straight cath if needed or if you have an order, pelvic floor exercises, and also put them on a scheduled voiding. You're going to do scheduled voiding with them, For the NCLEX tip, in a lot of questions recently that I've kind of reviewed, they're always kind of looking for reversible causes first. So like medications or obstruction with urinary incontinence and retention. So it's a lot of ruling out things. So just keep that in mind. Okay, first we're going to talk about acute kidney injury and chronic kidney disease. So first, AKI is a rapid loss of renal function, hours to days. Your patient will have oliguria, anuria, azotemia, fluid overload, and hyperkalemia. This is often in the hospital or ICU settings. 14% of hospitalized patients, it was found, develop AKI. So persistent AKI leads to worse outcomes for the patient. Nursing priorities for AKI is monitor eyes and nose, electrolytes, specifically the potassium level. You're going to avoid nephrotoxic medications, so make sure you know what nephrotoxic medications are, and dialysis support if it is needed. So in AKI questions, you're always going to monitor the potassium, so peaked T waves or hyper K is life-threatening. For chronic kidney disease, you'll see a gradual decline in renal function over months, years, stages 1 through 5. Manifestations are hypertension, anemia, bone mineral disorders, uremia, and fluid overload. So for chronic kidney disease, for your nursing interventions, you're going to manage complications, anemia, bone disease, fluid, nutrition, and prepare for renal replacement therapy if needed. So NCLEX tips and tricks. So the mnemonic rifle, AKIN, and KDIGO for AKI staging, making sure you understand the definitions. So for glomerular disorders, think of nephritic, I for inflammation, hematuria. Nephrotic equals massive protein loss. So in exam stems, you're going to always evaluate volume status. potassium levels, BUN and creatinine, and edema as key clues. And before you're going to give diuretics or fluids, you're always going to check renal function and the potassium level. And always prioritize life threats, so hyperkalemia, fluid overload leading to possible pulmonary edema. Your patients can also have severe hypotension from renal failure and metabolic acidosis.